Hello, everyone. This is Mike Steckline with the Institute for Enterprise Excellence. Today, I'm actually at Hennepin County Medical Center. The folks here are going to give a great presentation. Originally, it was planned for October, but they agreed to come back and do it for us in November. Little housekeeping details. As always, the phones are going to be on mute. I'm going to unmute them later on during the Q&A session. And in the time prior to that, you can use the chat function to ask any questions so we can pre-anticipate and work on those questions as we proceed. This webinar is being recorded. If you want to share with others after the session and also forward to anyone that might benefit from learning about this great work, please do so. As I said before, originally the group was going to talk about the work that they had done on the reduction of catheter-associated urinary tract infections, and that was Plan A. Plan B had to be pulled in when the Joint Commission showed up on the day that we planned to give this presentation. Maybe they'll share their learnings from the Joint Commission visit. I do understand that it went well and everyone survived that. And so now we're back to Plan A, the original Plan A. So the presenters today are going to introduce themselves. We've got a number of them assembled here in the room, and they're going to talk about the work that they did to achieve some sustainable improvement in catheter-associated urinary tract infections. So I'm going to turn this over to Linnell, and she's going to take it from here.
All right, hello, my name is Linnell Scullard. I am the nurse manager here in the Surgical Intensive Care Unit at Hennepin County Medical Center. I've been the manager here for about 5 years, but I've been in the Surgical Intensive Care Unit for 24 now, I believe, in various roles. And so I've seen CAUTI from many different perspectives, but really was my charge as the manager about 5 years ago to start working on this. So you'll see that in the presentation, how it evolved over time.
And my name is Dr. Caitlin Eccles-Radke. I'm an infectious disease physician here at Hennepin County Med Center. I have just been involved over the course of 2017 with the Catheter-Associated UTI or CAUTI program, and was pulled in sort of as a physician on the team to make sure we had people from sort of the provider standpoint, the nursing standpoint, the administrative standpoint, et cetera, to kind of have an all-encompassing team.
And my name is Mary Hassler, and I'm a lean advisor here at Hennepin County Medical Center. And I have spent most of my career in manufacturing and have a medically intensive kid, and was thrilled to join the team here to help focus on improving processes in healthcare.
All right, so I'm going to go ahead and just sort of get us going. We'll start with the setting. So Hennepin County Medical Center is a level 1 trauma safety net hospital right in downtown Minneapolis, directly actually across the street from US Bank Stadium. So as you watch the Super Bowl, you'll probably see a little bit of our hospital here and there. A lot of planning going on with that actually around here. So we run, if we have 425 patients, we have a really high census, and we can go up to 440 to 450, but for the most part, we run about 380 to 400 beds every day. The Surgical Intensive Care Unit, 20 beds. We have about 65 RNs and 20 physicians that really kind of run the show. We are a teaching hospital, so we are very resident run, so there's actually more physicians than that around at any given time. We are not a closed unit, and what I mean by that is not just a surgical service can be in charge of patients in our unit, but neurosurgery, ENT physicians, orthopedics, those kind of things would also be the primary service in our unit, which has positives and negatives when you're trying to do some process changes. Sometimes it can get a little bit in the way for us. The patients we typically take care of, we have a lot of trauma, being a level 1 safety net hospital. We are very focused on trauma, traumatic brain injury. We get the strokes. We have complex surgical patients, and then we do some cardiac surgery here. And so they actually come to the Surgical Intensive Care Unit post-operatively.
So in terms of Hennepin's lean journey, you can see on this slide, it's a bit of an eye test, but the lean office started up in 2007, and the progression has kind of followed what has happened in many facilities. You know, we started out being very tool-centric, then we moved into doing Kaizen events and just kind of went crazy with a number of weekly Kaizen events. And then we moved kind of into looking at the management system, and we focused on visual management boards, was kind of about the board rather than about the thinking. And then in 2015, we engaged with an international consulting organization called Lean Pathways, and they've been helping us build a management system both for daily management and strategic development and deployment. And the significant part about the SICU is in 2015, Linnell and her staff were a model cell. And so they were engaged in working on a process for counting their controlled drugs. And they learned how to do daily management in that with that simple process. You can hear our PA system overhead. So that's where Linnell really cut her teeth with some of this basic lean stuff, right? Then in 2016 and 2017, she became engaged in the CAUTI work under the quality and safety pillar for strategic deployment. So she's really had a lot of this good lean stuff for 3 years and has really grabbed onto it. And as you'll see, been successful using it.
All right, so what is our problem? Why do we care? What do we need to do? So we always like to compare ourselves, to ourselves and also to other organizations within our area. So in Minneapolis, we looked at the other hospitals here in the Minneapolis area. We have North Memorial, who's a like hospital. They're a level 1 trauma center. And then Regents is also a like hospital over in St. Paul as a level 1 trauma center. So we tried to compare ourselves to folks who are like us and how are we doing with our CAUTI rates. And what the the CMS, the Centers for Medicare and Medicaid Services, want us to be is under what they call a SIR of 1. So that's a standard infection ratio, and basically it's what you have over what is expected. And less than 1 is always the goal. And if you can see on the slide on the far right, all 3 hospitals are actually greater than 1. But if you look at the bottom at Hennepin County Medical Center, we were significantly over what observed to expected. Interestingly enough, if you also look at this, if you look at the catheter days associated, that's the one, the third, it's the middle column. Both of the other 2 organizations had a much higher number of catheter days in their organizations, and yet we had a higher rate of infection. So what is going on in our institution? That's what we were to discover. Also of note, in the surgical intensive care unit in the year 2015, we had 13 CAUTI, and that was a third of all the cases in the organization. So we owned a fair amount of the CAUTI in the organization, besides having a higher rate overall than our like institutions in the area. So here's the challenge. When I first became the manager the first year that we started monitoring this, we actually had 52 CAUTI. And so holy buckets, right? But we decreased and we improved and we improved. So it's kind of like, well, we're doing really good. So why is this still a focus? We kind of felt like, you know, hey, look at this. We've cut it in half and almost cut it in half again. We had a little blip. We went up a little bit in 2016 to 16. But really, we thought we were improving and doing what we needed to do. And so it was sort of an attitude for us of why you know, hey, we're doing well. There's nothing that needs to be improved here. We're already improving. So then the other challenge for us was, how do we fix this? And Mary kind of went over sort of our early attempts at lean, our early attempts of thinking. My whole model cell project was pretty significant. Mary was my advisor. We spent about 3 months really trying to figure this out, as this is not how myself as a nurse thinks at all. And Mary was very patient with me, and for about 3 months we argued pretty much every day, several hours a day, about how was this supposed to go, and trust the process, and just kind of hang with me and whatever. So it was a lot of time spent really kind of getting used to thinking in a whole kind of different way, to be honest with you. So then it was great that, and I learned this process, but we were still doing work as a committee and still doing work as a pillar. And I was the one in the room who kept saying, now, wait a minute, when everyone else still kind of hadn't had this opportunity to have this intensive 3-month training one-on-one like I did. So we were still doing things as a committee rather than letting people who take care of the patients be participatory in that. So that was one of our challenges. We were also infection prevention team, who was a major part of our committee, was really, really focused on the protocol. And we had developed the protocol as a nurse-driven protocol in the very beginning, because we felt if the nurses made these decisions, we would take these catheters out, which we found to not actually be true, but that was the goal. And we weren't using the protocol as designed. And so that was sort of the assumption that we needed to fix. We needed to fix the protocol, because if we fixed the protocol, we were going to fix everything. So that was one of our challenges. And we were very resistant to that, because the protocol didn't work for what we as a nursing body and as a unit felt was the right thing to do for the patient. So there was a lot of resistance, and this isn't right, and you don't understand, and all those kinds of things that were going on about how do we make this better. We also, besides having decreased our CAUTI significantly, we're running a device utilization rate of about 70%, which is actually the surgical intensive care unit national average. So again, you know, if you're being told you have to take your catheters out, you have to take your catheters out, this is how you fix this, is taking your catheters out, we felt like we were doing the right thing because we were with where everyone else was in the nation. So we were very challenged with trying to figure out, should we improve? Why do we need to improve? And actually, can we improve? So here's what we did. So the first part of it, the top bars there, was the work that we were doing. And it was very by committee. It was, we had a team come in with our product that we have, the Foleys that we have, the catheters, and they did an assessment for us, and they found all these things based on research, based on national averages, based on what they believe to be what we need to fix. And that's what the top bars really focused on, was the things that they found. And they were standard of care, they were good things to be doing, and we've worked on some of those things, but we did not change anything with our CAUTI rates or device utilization or anything else. Nothing really changed, other than we were making sure we were performing the standards of care. So it wasn't quite the right thing to be working on. The other challenge was we had a lot of myths. So it was going to take us more work to do this. It was going to cause more skin breakdown if we had people, you know, wet all the time in the bed. We had a lot of things to tackle that had nothing to do with really the standard of care that was being assessed and then directed towards us as to what we needed to fix. So we were quite challenged. Eventually, finally, toward the end of the year, and that's kind of when Caitlin kind of got on board too, the physicians, is we got some other people on the team. And the main people on the team were actually some staff nurses. And they came with their perspective, and we kind of started completely over with what they believe is wrong, going down to the 5 whys, all those kinds of lean tools. And it was a whole different idea. And they were focused on those myths, that it's going to take us more work, that people are going to have their skin breakdown, that we don't have the tools and resources to do the job. That one of the things about the protocol that was significant was the idea of intakes and outputs. How much urine people made was a very important factor that ICU nurses measure every 2 hours. And it was considered not to be a valid reason to have a catheter in per the protocol. But if you assessed all the nurses and the physicians in the unit, they would say most of the time that is the reason why they left the catheter in. So what they felt to be important was not even part of the protocol. So we had this huge clash of what is right, what is wrong, what should we be doing, did we find the right problems? We also spent, based on what they were telling us, a lot of time getting the tools and resources. So we couldn't necessarily address the staffing concern with how long it took for the beds to be cleaned if patients were incontinent, but we did get scale so they could measure the linens to see how much, you know, urine people had out. We tried some different condom catheters to kind of catch the urine if we needed to help with that. We got some bladder scanners. We improved our diapers, so if we needed to use diapers on patients, it wasn't going to break their skin down. We focused a lot on the tools to kind of improve the process, to sort of minimize that you don't understand feeling. We didn't quite have it down yet, but we were working, we were getting there.
And what this diagram shows, I think it's really interesting. The top diagram was done by the committee that Linnell mentioned, and they were building out 2 branches on the Y tree that didn't end up being the root cause. And so then when we got staff involved, they built out 2 completely different branches on the Y tree, and then were able to get to that true root cause.
All right, so how do we help this? How do we fix this? We had this mental block, we had this mental model, we were resistive, we were improving, we were where the national norm was, why do we need to improve? We were really kind of stuck as a nursing unit. So we continued to leave the Foleys, the catheters in, as we felt were appropriate because we thought we were doing a good job. So we weren't really making any progress. We were just kind of playing along, if you will, measuring everything, doing what we were supposed to do, and still having UTIs, still having infections. So then our 5th test of change actually was, we noticed that most of our infections were happening after day 5. So we thought we'd start looking at that, like, can we can the catheter come out before day 5? Is that going to make a difference? So that was the 5th thing we tried. And this is what we measured. So every day in multidisciplinary rounds, which includes physicians and pharmacists and respiratory therapists and the nursing staff, including the bedside nurse, the nurse was to know how many days the catheter was in and to bring that up to the group in rounds. And that was our what we were monitoring, because if it's longer than 5 days, does this patient need their catheter? That was the intent of this. So this was the next test of change we did. And the nurses were the ones to bring it up in the very beginning, which is an important thing because it kind of morphed over time on actually how it went. And then we were plotting this for some time to kind of see if that would make a difference in reducing their catheter use. But we weren't really making any headway for a couple of weeks. And we'll show you the run charts here in just a second, and you'll see what we're talking about. The way our physicians round is a surgeon takes the whole entire week. And there was a week where Dr. Richardson was on, and on Monday, he actually ordered many of the catheters to come out during rounds, and only a few of them actually came out for various reasons. The nurses didn't agree, just didn't, a lot of things maybe that, you know, that's what had happened. And so then the next day, he actually came through and he discontinued every single catheter in the unit. I was actually in a different lean event somewhere else in the hospital, and I was getting phone calls and crying nurses, and it was quite a dramatic experience because it's like, we can't do this. You know, you can't just take all the catheters out today. But that's what he did, and I maybe wouldn't suggest that's how you go about doing things, but it did force us then to make some change. Almost every single catheter came out, 2 did not, and then actually many of the catheters went back in. But surprisingly, there were several, and I should have got the number now that I'm looking at this. I feel like half of the catheters we took out that day did not go back in. And that was probably the most significant thing, because, hey, people that we would have never tried in the past to take a catheter out had their catheter out. And funny, it worked. They didn't need a diaper. They weren't incontinent. They weren't crawling out of bed and falling because they had to go to the bathroom. All the things we worried about kind of weren't really happening. So that was a good thing. Even so, we were kind of forced into it, but it actually helped us sort of see the reality and kind of work through some of our myths. The other things that happened was, so we went to the extreme, right? We took them all out. Well, that wasn't going to work because some patients did need their catheters put back in. We actually had one lady have her catheter taken out, put back in, taken out, put back in. Through the protocol, we try 24 to 48 hours to see if they can, you know, void without it, 8 times over the course of her stay. So this was a lot of like work and time and conversation. But what happened in the long run is, instead of just saying, you know, the doctor would say, take it out, and the nurse would be like, I don't think I agree with this, but to me, not to the conversation, it forced everyone to sort of get together and talk about this. So what ended up happening was, in rounds, instead of the nurse just saying the catheter has been in for 7 days, and it's like check on the box, it was a real conversation that started to occur between the physicians and the nurses. Does this patient actually need their catheter? And that was the miracle that kind of drove us to the next step, because we actually were talking about the patient, what the patient needed, and we were working together as a team. And that's where we really started seeing some progress to be had.
Okay, so I wanted to share 3 successive run charts because they're just kind of classic process management, and I'm just in awe of what this team was able to do. So if you look at the first one, the black line is the target. So that's the number of Foleys that they have on the unit. And then the red line is the number of Foleys that were discussed during the multidisciplinary rounds that Linnell mentioned. And so you can see that when they started this process, though the target and actual are kind of far apart, and it's quite variable, right? So then you can see kind of towards the end of the month, on or about the 26th, they start to come together, where the number of Foleys and the number of conversations match, but there's still a fair amount of variability, right? Then if you move to the second run chart, you see that it stabilizes a little bit, and it's still above the target, right? Then as they continue these substantive discussions during their rounds, they continue to make improvements, and then on or about the 20th, they start to drop below that target line for utilization, right? Then if you go to the next chart, you see how, again, their variability is reduced, and then they drop down in utilization to an even lower level, to where they're now fairly stable and at about 40%. And so I just think it's so gratifying to me as a manufacturing process person to see Linnell and her multidisciplinary team, including Dr. Caitlin and physicians, grab onto these tools that can help them manage their process. So I just think these run charts are a beautiful story.
Need to frame them.
Yeah.
Don't lose them. So where are we at and what's happening now? So if you look at the chart here, on the right, you can see in July and August and September, we actually went back up on the use of our catheters. But I will say it has been since June 6th since we've had our last infection. So we are having the right patients with the right catheters in, because the goal isn't necessarily to take all the catheters out, and that's sort of been our story all along. We don't need to take them all out. We just need to take the right ones out for the right thing. We tend to have a lot of high acuity patients in the summer. It's a trauma season, and that's when we get a lot of them. So we did increase the use of our Foleys, but we did not increase our infections. And that's really what our goal is to make sure the right patient has the catheter in, and the right patients who don't need it do not have their catheters in. So this graph actually shows it quite well. So what has happened? So thus far, like I said, in 2016, we had 16 CAUTI. And so far this year, and actually it's through current state, we actually have only had 4. So we reduced it by 75%, which I never would have thought would have happened. Because who would have thought? The other thing that's happened is that we actually are down below 1 with our SIR, which is, I just didn't think it would ever happen. Sorry.
So the level of improvement that she's been able to make makes her emotional, right? And that's kind of a cool thing too. She didn't think her team could achieve this level of results, but you know what, they did.
Mm-hmm.
The other thing I would like to say is that they did this. They did this. They had to figure out how to work together. They had to figure out how to come to an agreement of the right decisions for the patient. And once that happened, I just monitored the process, and they have taken it on. It has become a life of its own. They do it. I just keep watching it. We've sustained it significantly. We've never had an issue since. A blip here and there, but really, nothing has backtracked. They own it, and it has become the way we do work now. The other thing that has happened is that the nurses on the team had, a lot of flack in the beginning, because, this isn't a popular thing to do, to take all these catheters out and have people potentially wet the bed or whatever. And it was more work. It is more work for the nurses to do this. And so they got some flack for it, but they stood up and they stood tall. And there's been actually a fun growth of those nurses into to some leadership skill to watch them. One was a very quiet, introverted nurse, and she is no longer that. And so it's been a good process for them to participate in as well. So it isn't just that it's been good for patients. It's actually been good for, the unit, the staff altogether. So what have we got here? So this is all of our parts. So we'll kind of just go through the corners. Leadership, in the beginning, they used to come, and I called it the dog and pony show, which I see made the slide here. And I was really good at that, because I can talk, and I can show, and I can sell, but we weren't really changing anything. My run charts were great. I was going down. We weren't doing this. We were doing that. I had everything perfect. I had everything plotted, and they came to see it, and we looked wonderful, but we weren't really improving anything. We just had beautiful run charts on the wall. So that was a good lesson for all of us. It's really about what you're doing, not how it looks. And I think that's an obvious, but we had to kind of grow through that to figure that part out. As far as leadership goes, for me then too, I always felt, I do kind of still, but feel extraordinarily responsible for the success of this. But when it just kind of took a life of its own, and it actually was more successful when I backed out. When I was more just watching the process than sort of pushing the process and saying, hey, we got to do this. Hey, we got to do that. Here's where we are today. We need to improve those kinds of things. My role really now is just to keep us up to date and keep an eye on it and make sure we don't fall off. And then, we do the visual management updates, and here's where we're at. But really, my involvement is nil compared to the work it used to be for me. For the nurses and the healthcare assistants in our unit, again, there was some leadership that was happening. They learned that they could do work differently and that it was okay. It was really hard to say this wasn't a good thing to do when we stopped having infections. So even though it was more work, even if no one believed this was the way to go, even if nobody felt that they had the right tools and resources to do this because we needed to have a catheter to know what our urine output was, it was really hard to argue the fact that we were no longer having infections. And so they all kind of, had to sort of open their eyes too to, well, sometimes what we don't think is going to work, we have to try and actually make it work. And then the providers as well, getting them involved was key to this. In the beginning, it was just nursing and infection control personnel. And then we got lean involved after a while. But when we got the providers in the room, then we had the whole team in the room because they come from a different angle. They have ordering challenges. They had in culturing things that we worked through. There's other parts to this than just obviously what SICU has done. But it really made a difference to actually have the entire team in the room who are doing the work through this process rather than a group of us just trying to decide what to do without really being the ones who are doing the work. So it was pretty significant that way as well.
The other thing, the multidisciplinary rounds are really effectively a form of a huddle. And so that was kind of integral to this process. And then I just wanted to point out that the providers did have a financial incentive to work on and improve the catheter process. So that kind of got their attention at least at some level, and might be a lever you all could use.
Does that mean compensation for time spent? Is that what you mean by financial incentive?
It means, so this is Caitlin. I let Linnell go through it because she tells the best story about all this. But what it means is we all have both institutional and individual incentives each year. And so the bonus that each provider potentially can obtain at the end of the year is dependent on whatever metric the administration chooses. And this year they, and rightly so, I think, picked the CAUTI project as the metric for the provider bonuses. It's just a small percent of everyone's salary. And the reason they picked this one, I think, in line with sort of the whole story you just heard, is because we really focused in on what the hypothesis was, and we had two main ones. One was, if we talk about Foley's on rounds, our utilization and total number of CAUTIs will go down, which, as you're seeing, happened and worked. And the second lever was about urine culturing practices, and that is very provider dependent because we're the ones who place the orders for the urine cultures. So they really wanted to pick a metric that was going to be achievable with the right process and measurements, and kind of change the whole culture of providers' interaction with the nursing team, with the patients, with the multidisciplinary rounds, and making good decisions for both catheter use as well as urine culturing practices to reduce the total number of CAUTIs in the hospital for the year.
Couple things. One, this whole process has actually created a workflow design for us that has worked in many other ways. So an example would be, we are a stroke certified center, comprehensive stroke center, and one of the things we've been challenged with is actually having the swallow study performed by the bedside clinicians prior to giving any oral medication or oral food. And we've been challenged with not always having it documented correctly. And as soon as I got a run chart made and got it on the wall and started really plotting the course of what we were doing and talking about it every day, it improved dramatically within the first month. So we've really learned that kind of really trying to find the right core root of things and then really kind of monitoring it and solving for it in a process way versus a people way has made a difference. So we've used this multiple times, the same process since, with great improvement in our unit. So what did we learn? I think it's hopefully obvious to you that when the staff got involved, they had to sort of problem solve themselves, not just even in the room, but actually out in the unit every single day. How do we make this work? How do we take the Foley out or not take the Foley out? And how do we make this decision? Once we kind of figured that out as a whole, that made a significant improvement, and that's where we started to move. It took a radical move on our part, which I guess I would say again is not what I would recommend, but actually we probably needed that kick in the butt to get us to try this, because we were kind of lingering on the fact that we thought we were doing okay. myself included. Daily individual discussions about the catheter use, again, at rounds, really, and that's going to be our tactic actually for next year for many different things. We're going to be using the same tactic to improve a lot of other quality indicators and things that the hospital is working on, because it's been successful in this case, so successful that they're actually using this work and this process as an example to work on other things next year. And I think the other thing is that we still keep an eye on it. I still check how many Foleys we have several times. Once in a while I come in, like on a Monday, and we'll have like a 85% device utilization rate, and I'll be like, what? What's going on? But you know, a couple hours later, many of the catheters are out, or they were appropriate. And so even though we've had an up and down with the amount of Foleys we're using again, it doesn't mean they aren't the right patients at the right time, and that was really our goal. So we just continue to watch it, and it continues to stay. Mary?
So I'm going to unmute the phones and see if there's any questions from anyone that would like to chime in and offer any thoughts or feedback. Phones are unmuted now. One of the things we were talking about before the session started was, so what are the kind of things culturally that need to change if this is going to be spreading to other areas?
I think I think the good part about starting out in the intensive care units, both the surgical, and we actually were doing the same process in the medical ICU. It was nice because it was a bit more of a contained group of people. So I think some of the difficulties we've seen rolling out to other units are that, you know, other units have teams from various areas. So it's just a slow progression of sort of changing the culture of why this is important. And I think to Linnell's point earlier, getting the people doing the work to understand why it's important and find ways to do it that work with their workflow rather than it just coming from the top down. It really has to be the involved parties helping to get creative and innovative and make decisions about how to do things so it fits into their workflow. Otherwise, they will just fight it.
And I think one of the things that we've helped our senior leaders see is that you can't take something that's successful on one unit and just cut and paste it into another, because sometimes the root cause isn't the same. And so we've encouraged them to go back to that step one in the problem solving process and define where is the gap on the unit that we're trying to spread this work to, and is it similar to the problem in the previous unit? And if so, then you can adopt that same change. If not, you need to sort of explore what would be a countermeasure for this new root cause. And in a similar vein, like Linnell was saying earlier, you can't just take a protocol that's widely used out in many hospitals and plop it into your hospital and think you'll get improvement. You have to really sort through, where am I deficient in this protocol, and figure out my root cause and then tackle that. So I think that was kind of a big learning for some of our leaders that really felt this copy paste was the answer.
I appreciate that. I can tell you, when I first heard this story, it's been a couple months ago, I was very excited about sharing it with others, and then pleased that Mary and the team agreed to share it, because I think it's the reason why a lot of us got into healthcare. And every one of us is going to need healthcare one of these days. Our families need healthcare. And whether you work in healthcare directly or not, this kind of improvement work is critical. And it's a great example. I know Mary was excited about the run chart picture, but I was so pleased with all the great work that you guys have been making. And it's a good example of a sustained improvement as well. I really like that in this story. I'll pause to see if there are any questions or comments from anyone on the line. Quiet group, they're ready to get on.
I have one more question.
Yeah.
Is anybody from Health East out there? No?
No.
I want to give them creds for the format of the run chart.
Okay.
I had an opportunity back in 2015 or early early 2015 to attend a training there, which is where I met Mike, and they were using this in their lab. And so John Calidora sent it to me and I completely copied it. So thank you, Health East.
Great. Well, knowledge goes across boundaries without a visa, as my friend Dr. Deming would say. And so I'm going to close now.
Hey, Mike.
Yes.
Mike, this is Dan Weber calling from Scripps here in San Diego.
Hey, Dan.
Good to hear your voice. I had a quick question for the team about how learnings related to their CAUTI efforts have informed work on other safety-related efforts that either the board may find important, the organization may find important. How is the big system responding to some of these learnings about where and how we can be most effective in solving these problems?
Go ahead.
This is Caitlin. A couple things. So one, I think the administration is for sure responding. I mean, they've seen the work that's been done by the CAUTI team and all the nursing staff and providers on the floors, and are recognizing it. So it hasn't gone unnoticed, which is nice when you're working hard on things. You know, I think we have brought our project to the board for the hospital and have presented this in around the Twin Cities as well in a couple different ways. And so I know that sort of they're recognizing that the process improvement and how the project has been done is helpful. And I think are starting to, as Linnell mentioned on her unit, and I think for future projects for next year are starting to kind of use the same ideas, kind of tight-knit teams, working with lean, working with providers, working with nursing staff, and sort of all the players in order to work and move forward for process improvement. They're using some of the similar functionality in terms of pressure ulcers and central line associated bloodstream infections as well within the hospital. And Linnell, can you comment on anything else?
I think they're kind of designing it too for our sepsis guidelines. We're still struggling a little bit with getting our sepsis guidelines all intact and consistent. And then for actually multidisciplinary rounds is a pillar project next year, and they're, as an overall pillar, they're going to be using the same exact process of measuring and having the team solve for themselves, because like Caitlin said, you know, some teams, there's a lot of different teams that round on some units, and how do you actually manage multidisciplinary rounds and what is the expectation of them? So they're really taking this simple little process that we did and expanding it to work for everything. So we'll see how it goes, but it certainly has been working for us, and we can demonstrate it's working in all of the parts that we're doing now. So,
and we have an annual planning process that Linnell and Dr. Caitlin are referring to, and we have 4 pillars, and there's a quality pillar, and one of those focus areas is mortality, and like Linnell mentioned, the sepsis and some of the other quality indicators that they're going after fall under that mortality topic. And so we're using this A3-based strategic planning process that has a very regular cadence and coaching by our executive team. And this will be now our 3rd year with Lean Pathways coaching and mentoring. And so it's really, you know, the progress that we've made as an organization in tightening up the way we do that strategy development and deployment is really awesome to see.
I think what's missing probably in the presentation, now that I think about it, is the value of the daily management system that goes with this. So every day we would talk about what happened with our catheters yesterday, or now I look at skin and I look at CLABSI and I look at, you know, several different things. We measure restraints every single day. And I think that's what's probably the driver at the bedside or in the unit that's making the change, that I think is what's really moving forward with all of these other initiatives that the hospital is doing, is that sort of expectation of a daily management system where you measure things and you talk about them every day and then you problem solve them right there. Like my huddle's at 7 in the morning. We talk about, like, for instance, central lines. If we missed a dressing, it wasn't dated, whatever was happening with the dressing. You know, I would talk about the next day saying, hey, you know, is there something I need to know? What can we do better about this? It's just every single day keeping these things in the forefront, and how do we engage the staff right then and there to help us solve them. And I think that's where the organization's moving, that sustains and improves all this work.
And I think one more comment to that note of Linnell's. In addition to the daily management on the units, I think from a project management in terms of our CAUTI team, we had a lot of consistency and routine as well. Like every Tuesday, I would meet with people from the lean team as well as the VP of Quality and Safety and Chief Quality Officer, and we would have our plans, what is our plan for this week in our full team meeting. And then every Thursday we had our full team meeting with planning, data, and sort of next steps, and sometimes go-sees where we'd go check out the units to sort of see what was actually happening versus what we thought was happening. So I think consistency in various forms was a huge component to this, because it was just, you got in the habit of the routine meetings, the routine coaching, and it just became something that, we routinely didn't miss. And I think having that consistency was part of the success too.
So the only other thing that, this is Eni. The only other thing that I would add to, as far as the value that the organization is seeing. So the Joint Commission came in, as we know, because this got canceled, but they've even started to use the process of the 4-step problem solving to look at any of the findings in Joint Commission and what can we do so that we don't have repeat offenses in the future.
Great, thank you. Dan, thanks for the question. Okay, any other questions from the group? Perfect. Well, again, I want to thank the team that's assembled, and also the team that pulled this together, and congratulations again. What happens next is the recording from today's webinar on our website moves over to the recording session, and that's where you'll be able to find that. The next webinar is going to be December the 8th. Friend and colleague Dan Markovitz, who's someone that I recommend people read his book, Factory of One, but he's written another book called The Fit, or Building the Fit Organization, and he's going to be talking about that. He's got some great metaphors about personal fitness and talking about fitness of an organization. So looking forward to that. If you want to find out about what he's going to be talking about, go to the bit.ly link at the bottom of this slide. On January the 26th, Kevin McNamara, also a friend and colleague with Tidy Products in Neenah, Wisconsin. He's the CEO that shared an example of his standard work for the CEO, and his experimentation over the years about what he's been doing, and he's willing to share his current experimentation with leader standard work. And again, information about that can be found on the bit.ly link on this slide below. Some topics that are in the works: daily intentional practice, a lot of what the team was talking about today. Katie Anderson is going to put together a presentation, the date and time to be determined. And then some friends from Sandoval Regional Medical Center in Rio Rancho, New Mexico, Corrine and Melissa, are going to be talking about the application of this principle-driven transformation in their areas of responsibility. Corrine is the HR leader, Melissa's the communications leader, and they got some great examples to share about how they're applying this in their work. I know that there's other stories that are out there, and I'm always on the lookout for those. So if anyone has examples of stories they'd like to share, or suggestions of problems and stories they'd like to hear about, please send them to me at that email address there. And you can also connect by joining our group on LinkedIn. So I want to thank again the team for the work that they did in today's presentation, and hope that everyone has a good day. Thanksgiving's coming up, so everyone have a good Thanksgiving. And thanks again for the team putting this great presentation together. Bye-bye.